Hi there, this is Nursing It, and in this video we're going to talk about depressive disorders and bipolar. The nurse's role when caring for patients who are experiencing depression is really to listen, convey empathy, validate the concerns of the patient, use therapeutic communication, encourage the patient to communicate openly and honestly about their feelings, and to maintain safety as much as possible. I think this picture sums up beautifully how difficult it is to understand what someone is going through during depression. But people oftentimes report that they have true physical pain as well as emotional pain during a severe depressive episode. All races, ages, and genders are susceptible to depression. No one is immune. Major depressive disorders are a combination of symptoms that interfere with your ability to work, sleep, eat, and enjoy usual activities. So they impair your work functioning, your social functioning, your self-care or ADLs, as well as create a sensation of anhedonia, which is a lack of enjoyment. In order to qualify as a major depressive disorder, the patient must experience 5 or more of the following symptoms for at least 2 weeks. A depression in mood nearly every day for most of the day. Worse in the morning that may get better as the day progresses. An inability to sleep or oversleepiness. Increase in fatigue and agitation. Frequent feelings of guilt or self-worthlessness. Changes in weight and appetite. Anhedonia or a loss of enjoyment. Decreased ability to think, concentrate, or make decisions, and recurrent thoughts of death, self-harm, or suicide. So think about major depression as interference with ADLs. They're not able to care for themselves. They withdraw from the people around them, and they can't find pleasure in normal activities. A persistent depressive disorder, also known as dysthymia, is different than major depressive disorder. This is a depressed mood for most of the day, more often than not, but not every day. And it may be subjective, so they tell you they feel that way, or objective, for at least 2 years for an adult or 1 year for a child. They must present with 2 or more of the following symptoms. Also a change in appetite, so poor or overeating. Also a change in sleep, too much or too little. But as opposed to major depressive disorder, people with dysthymia tend to feel better in the morning, but they worsen as the day progresses. They often experience low energy or fatigue, low self-esteem, poor concentration or difficulty making decisions, and have a persistent feeling of hopelessness. Other depressive disorders that are important to mention are things like premenstrual depressive disorder, where the patient experiences mood swings that occur the week before menses and cause significant interference with work, school, and social relationships. Depression can also be related to substance or medications or other medical conditions. When a patient is taking substances or medications, they can experience depression with intoxication or with withdrawal. These include substances such as alcohol, opioids, antihypertensives, benzodiazepines, steroids, and chemotherapy drugs. Depression can be also due to medical conditions such as hypothyroidism, Addison's and Cushing's disease, vitamin deficiencies, usually vitamin B deficiencies, systemic lupus erythematosus, congestive heart failure, and many others. It is important for the nurse to always obtain a thorough history and to do a physical exam to assess for and rule out medical conditions such as hypothyroidism, etc. The admission assessment is the perfect time to collect and organize all this data to help determine whether or not there's possible underlying medical or substance use. There are many theories regarding the etiology of depression. The cause is not completely understood, but it's likely to include a combination of genetics, biochemical, and environmental factors. These contribute to neurotransmitter imbalances in the brain and changes in mood and pleasure. There is sufficient evidence to suggest and demonstrate that depression truly exists when you look at pictures of neurotransmitters and actions within the brain. Developmental considerations in children include children cannot express themselves easily, especially younger children, so careful screening and assessment is vital. You need to understand the developmental norms for children because the symptomology is going to differ by age. And then you need to recognize if children are achieving those expected developmental milestones and look at whether or not they're experiencing any issues in school. Therapy is used in children fairly successfully, and it's focused on coping skills and usually involves the family. Medications can be used in children. Prozac has FDA approval for children under the age of 12, and Prozac and Lexapro both can be used for children over the age of 12 and under the age of 18. Children can become suicidal and do need to be monitored carefully. Adolescents present with many of the same challenges for diagnosis because symptoms and behaviors are often confused with normal development. It is not uncommon for an adolescent to experience sadness, loneliness, hopelessness, and anxiety as a form of depression, and then these are often perceived as normal growing up emotions. Other things that we may see that are kind of hallmark signs of depression in adolescence would include anger that is misplaced or inappropriate, excessive aggression, and then behaviors that should not be displayed by the normal coping adolescent, like running away from home, delinquency at school, social withdrawal, sexually acting out, substance abuse for self-medication, restlessness, and apathy. You may see loss of self-esteem, sleeping and eating disorders, and psychosomatic complaints. The diagnosis of depression in adolescence really revolves around behaviors that change and last for several weeks. Keep in mind that suicide is the second leading cause of death in this age group, and there is a black box warning for antidepressants used with adolescents because of the increased ability to follow through on plans for suicide. Depression is very common in the elderly. There is a high potential for missed or misdiagnoses when considering all of the other medical and medication-related complaints that the elderly often have. Antidepressants should be used with caution because of the risk of suicidality. Electroconvulsive therapy can be very effective in the elderly when medication cannot be used or as an adjunct therapy. Postpartum depression, there are different stages. It's important to remember that hormonally, the postpartum blues are very common and very normal. They usually show up within a couple days after birth and resolve within 2 weeks. The mother is able to completely care for herself and the child. There's no dysfunction. Postpartum depression can show up at any time during the first year postpartum, and it has the same symptoms as major depressive disorder, but includes feelings about being unable to care for the baby or lack of interest in the baby. The person has impaired self-care and baby care abilities. The onset is usually later than the baby blues. Postpartum psychosis develops for patients who have a history of bipolar, and this includes restlessness, insomnia, and irritability, and usually persistent thoughts of self-harm and morbid thoughts of harm to the baby. This is a psychiatric emergency. The baby and the mother should be separated so that the baby is not injured by the mother. The mother usually requires emergent inpatient admission and medication for stabilization. It's important to note that not covered in our book, but that fathers can also experience a postpartum depression related to a decrease in testosterone immediately after birth. Treatment for depression includes therapy and medications, as well as ECT. Medications usually are aimed at replacing neurotransmitters in the brain. And since the monoamine group is the major classification that modulates the mood, we usually look at kind of adjusting the monoamines. So monoamine oxidase inhibitors you think would be a great place to start. It would stop the enzyme from breaking down the monoamine in the synapse. The problem that we get into with MAOIs is that there are so many side effects and so many other foods and medications that you can't take with them that it tends to become a dangerous drug, and so oftentimes not a first-line medication. Tricyclic antidepressants were used largely before, and some patients do still take them, but oftentimes we're using these now for things like Parkinson's. Then we have our tetracyclics and heterocyclics, and we do use these things like Wellbutrin fall into this category, and those are used especially for patients who have compulsions and who have other addiction disorders. Serotonin and serotonin norepinephrine reuptake inhibitors specifically work to extend the action of these neurotransmitters within the synapse, which makes the receptors feel like they're getting more of the neurotransmitter, and these tend to really do a nice job elevating mood. Atypical antipsychotics like Abilify are partial dopamine receptor agonists, so it's basically like a synthetic stimulant that will give a dopamine-like response in the synapse. And then there are like naturopathic options like St. John's wort that have not demonstrated efficacy in controlled trials. To give you an idea what the three primary neurotransmitters do in the brain, we have norepinephrine, dopamine, and serotonin, which are monoamines that work in those synapses. Norepinephrine really works on alertness, concentration, energy. But I want you to remember that norepinephrine is an alpha drug. It really is released by the body in terms of fight or flight. It really, think of it as like a stimulant. And when you have an imbalance of norepinephrine, and especially when you have an imbalance of norepinephrine and serotonin, you may experience anxiety, poor impulse control, and irritability. And when you have an imbalance of norepinephrine and dopamine, you have problems with attention. Serotonin deals with the ability to control your obsessions and compulsions and your memory. When you mix serotonin and dopamine, that is when you start to have problems with appetite, sex, and aggression. And then dopamine really works on your pleasure, reward, and motivation system. When you mix all three, or you have an imbalance of all three overlap to help control mood and cognitive function. So depending on the patient's symptomology, sometimes you want a serotonin reuptake inhibitor, sometimes you want a serotonin norepinephrine reuptake inhibitor, and sometimes when you're doing one of those and it's like an SSRI or an SNRI and it's not enough, You may add something like Abilify, which helps stimulate those dopamine receptors, and then you have come at the mood issue from kind of all three sides. Just to give you a visual of kind of how this all works at the synapse, normally you have all of the little kind of fuchsia colored triangles are the monoamine transmitter. So we'll say here that it's serotonin, and it's being released from the left side to the right. It's in the synapse and it's stimulating the receptors on the right side. You see the little guy up there that's kind of in purple. He's the enzyme, the MAO enzyme that kind of eats up or destroys the neurotransmitter. So it breaks it down so that you don't have overstimulation. And then you also have the monoamine reuptake pump that kind of collects the leftover serotonin and puts it back into the vesicle so it could be released again. So both of them are working at the same time, where the pump is reuptaking the serotonin at the same time that the enzyme is destroying any leftover serotonin in the synapse so that the receptors aren't hyperstimulated. In depression, you see that there's very little serotonin released into the synapse, that the receptor sites are not getting that lock and key mechanism, so they're not being stimulated, so they're not having that kind of happy mood effect. And there's very little for the reuptake pump to catch and put back into the vesicle, so there'll be even less for the synapse to secrete the next time. When you take an SSRI, the serotonin is increased because we don't reuptake it, so it stays in the synapse longer. And as the body makes more serotonin, kind of it's replenishing its stores. So now it's able to engage those receptor sites and stimulate a positive response. When you are medicating a patient with antidepressants, it's important to remember that these medications can take up to 4 weeks to demonstrate a therapeutic effect. So patients need to be educated about continuing the medication even if they don't feel better initially. Patients who are on antidepressants have an increased suicide risk, especially in the first 6 weeks as they're reaching a therapeutic level, because they finally feel empowered to act out their plan. Depending on the medication that they're taking, you should educate them on the expected outcomes, side effects, and any adjunct therapy, and then continue to monitor for those side effects and expected effects. One of the medication classes that requires a lot of education are the MAOIs, or the enzyme inhibitor that prolongs the effects of dopamine, serotonin, and norepinephrine in the synapse. Patients must be instructed to not take any medication, including over-the-counter meds, without first speaking to their pharmacist or physician. And then their diet is also restricted. They can't have wine, aged cheese, avocados, aged meats, or smoked fish. So no sulfites, no nitrites, and no preservatives. Medications, barbiturates, Demerol, tricyclic antidepressants, SSRIs, antihistamines, central nervous system depressants, antihypertensives, cough and cold medications, asthma medications, and decongestants will all cause an interaction with Nardil, Parnate, and Marplan. So that's why they say on here, no popular meds, because it goes with the 3 drugs. The signs of an MAOI interacting with a med or a food that the patient has taken is sweating, tremors, elevated temperature, bounding heart beat, like they can feel their pulse, and an elevated blood pressure. These are very similar to what we see with serotonin and neuroleptic malignant syndrome. So all of these are problems with hyperstimulation of the monoamines. Serotonin syndrome occurs when the patient has usually increased or added in another serotonin prolonging medication. And you can see this with just the antidepressants, but you can see this with other medications that are added as well. The signs and symptoms are very similar to the MAOIs, but diaphoresis, tachycardia, agitation, mydriasis, so they have dilated pupils, increased bowel sounds and diarrhea, autonomic instability with usually hypertension, clonus and hyperreflexia, and then tremors. And the treatment for this is benzodiazepines. Other side effects that we may see with our antidepressants and our antipsychotic meds as well include pseudoparkinsonism, where the person has stooped posture, shuffling gait, kind of joint rigidity, bradykinesia, tremors at rest, and pin rolling motions of the hand like someone who has Parkinson's. Akesthesias, where they have restlessness of the lower legs, trouble standing still, pacing the floor, feet in constant motion, and rocking back and forth. And then acute dystonia, where they have problems basically with the cranial nerves, facial grimacing, upward eye rolling, muscle spasms of the tongue, face, neck, and the upper back, like a kyphosis kind of spasm that causes the trunk to arch forward, and laryngeal spasms as well. And then tardive dyskinesia, where the tongue protrudes and rolls, sucking and smacking of the lips, chewing and facial movements and tics, and then involuntary movements of the body and extremities. The treatment for this is anticholinergic drugs to stop the interaction. Just a little bit more on tardive dyskinesia and neuroleptic malignant syndrome so that you have the information, but these are kind of the textbook definitions. The risk of tardive dyskinesia and the potential to become irreversible are believed to increase with duration in treatment and total cumulative dose of antipsychotic drugs. Tardive dyskinesia can develop after a relatively brief treatment period, even at low doses, or after discontinuation of treatment. Prescribing should be consistent with the need to minimize tardive dyskinesia. If the antipsychotic treatment is withdrawn, tardive dyskinesia may remit partially or completely, but it is possible for it to remain forever. Neuroleptic malignant syndrome is potentially fatal, and it is reported in association with administration of antipsychotic drugs. We see this as hyperpyrexia, so high fevers, muscle rigidity, altered mental status, and evidence of autonomic instability, so high blood pressure. Additional signs may include elevated creatinine phosphokinase, myoglobinuria like rhabdomyolysis, and acute renal failure. Manage NMS with immediate discontinuation of the drug, intensive symptomatic treatment, and monitoring. This is one of those things where patients who are taking something like Thorazine in long-term care are often misdiagnosed as being septic and are not treated and transported to the ED fast enough, and that can become fatal. Bipolar and related disorders are similar to depression, but classified separately. These occur equally among males and females, and they're usually diagnosed between the ages of 15 and 24. They're actually more common in higher socioeconomic groups and characterized by recurrent patterns. Comorbidities are very common with bipolar disorder. Bipolar 1 is the manic. So the patient has at least one bout of mania with or without depression. Bipolar 2 is the patient who has at least one bout of major depression with periods of hypomania, but they never really become manic. Cyclothymic is a kind of variety of bipolar disorder where the person has a chronic mood disturbance for at least 2 years, and they have numerous bouts of depression and hypomania, but it's less intense than major depressive episodes. And then there's substance or medication induced, very similar to depression, but the person can have mania, from substances or medications with either the intoxication or with the withdrawal phase of the substance or medication. And these are drugs like amphetamine, alcohol, cocaine, and steroids. We don't know clearly what the cause of bipolar disorder is, just like depression, but we believe it's related to an imbalance of serotonin, norepinephrine, dopamine, acetylcholine, and glutamate. There are definite anatomical changes in the brain that are demonstrated with SPECT scans. There's strong evidence to support a genetic link for bipolar, just like depression and schizophrenia, and the environment, medications, and conditions can be triggers. Mania itself has kind of subcategories. So hypomania, which is what goes along with bipolar 2, is an elevated mood with underlying irritability. The person is engaging and charismatic, but cannot connect deeply in relationships or even in conversation. They often talk very loud, they laugh a lot, they're very inappropriate and sometimes sexually suggestive. They display reckless, irrational, and erratic behavior, and substance abuse is very common during these hypomania phases. In acute mania, which would be our bipolar 1, the person needs to be hospitalized. They have a very labile mood, so they may be happy and then they may be angry, but they're very up and overly exaggerated. Excessive spending is very common. They may go on incredible shopping sprees, either in person or online. They could go for days without sleep. Speech is very rapid and disorganized, and they usually have flight of ideas, so they jump from one thing to the next. Cognitive function is significantly declined during acute mania, and the person has a hard time focusing and cannot perform self-care. Delirious mania would be kind of the worst of all of this, and the patient has an altered level of consciousness and stupor. Delusions and hallucinations are common during delirious mania, and they may be agitated and have purposeless movements. Treatment for bipolar includes hospitalization during acute mania for safety, medication, balance, and nutrition. Support groups, family therapy, and cognitive therapy. And all of this really is to help the person maintain a sense of control over their disease process. When you as the nurse are interacting with a manic patient, safety is your priority. You need to protect the patient, yourself, and others from injury. After that, think about nutrition. The person needs adequate food and fluid intake because they're unable to focus on themselves or their ADLs. When you can get the person to rest, sleep and rest are important, as well as providing a therapeutic milieu. Anytime you are with the manic patient and they are interacting with someone else, you need to be on high alert, monitor their mood, and as soon as you notice that they're becoming agitated or kind of elevated interaction with someone else, move them to a quiet environment as needed so that they can de-escalate. Clear, firm limits are incredibly important. Use a low voice and speak in a very calm manner to avoid escalation. They should be in the least stimulating milieu possible. Focus on reality. Do not argue with the patient. Monitor carefully for violence and keep any potential hazardous objects away. Security or the nurse should wand and search the patient and remove all potential items as well as belongings from patients that are either suicidal, homicidal, depressed, inpatients, schizophrenia, mania. Most departments have a policy that people who are inpatient mental health clients cannot have their own items. We allow freedom of movement because to contain a patient against their will obviously would be false imprisonment, but you want to make sure that they're safe. And taking somebody who's manic and putting them in a small room would increase their anxiety. Disruptions with other patients may be an issue, so again, remove them from that environment and allow them to de-escalate. Offer high protein, high calorie foods that can be carried as the person is walking and talking, and encourage them frequently to eat and drink. Promote a very structured routine with times for sleep and rest that the patient can follow. Lithium is the medication of choice for bipolar disorder. There still are multiple side effects. Sedation, fine tremors, dry mouth, GI upset, frequent urination, and weight gain are common as this works on the sodium channels. It does require regular blood work to make sure that it's a therapeutic level, as well as monitoring of electrolytes. 0.5 to 1.2 milliequivalents per liter is considered therapeutic. Dehydration is incredibly dangerous for the patient who's taking lithium. Again, they need to drink plenty of fluids and they need to have adequate sodium intake. Signs and symptoms of lithium toxicity include nausea, vomiting, diarrhea, blurred vision, difficulty ambulating, increased sedation, and ringing in the ears. The medication must be taken daily and should never be stopped suddenly. Patients who stop their mental health meds suddenly are very similar to patients who stop anticonvulsant meds suddenly, and they will have a severe swing in the opposite direction with acute onset of their mental disorder. They should report side effects as soon as they notice them and use lozenges for their dry mouth and perform good oral hygiene. They should not become pregnant while on lithium. Patients who are taking anticonvulsants as well for bipolar disorder should be taught about their medication and encouraged to take it as directed. Things that can help enhance patient adherence to medication use would be to take the med with food or milk to decrease GI upset. Remind them that it may take several weeks to work. Many anticonvulsants, because they suppress the central nervous system stimulation, will cause sedation. So caution with driving or using machinery until you know how the medication affects you. These medications oftentimes also need regular blood work, such as CBC, to monitor for agranulocytosis, aplastic anemia, and thrombocytopenia. Platelet levels and coagulation studies are done for valproic acid, which is Depakote. And then remember that Depakote is also the one that we monitor the gums and do meticulous oral care. Monitor for bleeding, jaundice, and rash. Avoid alcohol with anticonvulsants. And remember that there could be a decreased efficacy of oral birth control with certain medications, and certain medications are not safe to be taking while you get pregnant, so the patient should talk to their provider about alternate forms of birth control. That is it for depression and bipolar. Thank you for watching.